some concerns about the audio.
Yeah,
Dr.
perfect, sir. I think it is perfectly audible, sir. The slides
Thank
are
you.
also visible.
Thank you, and thank you to Dr. Jatin Mistry. I think he did a wonderful job to set the stage for today's panel discussion. We just wanted to dig deep on what actually therapeutic hypothermia means as Indians. Why there is a controversy in the first place? Why should, as somebody rightly asked, why should a baby be different from LMIC to HIC? The same thing for surfactant use. We don't see different meta-analysis coming for HIC versus LMIC. We don't do the same thing for any other newborn interventions. So in that case, why should therapeutic hypothermia be set aside as a different modality of treatment where only certain high income groups can benefit? That's totally different from whatever we have been used to and whatever we have been trained for. So just a brief objective of this session would be to explore what current status of research, what we will real world experiences. We have great panelist team amongst us today, and they come with decades of experience. And hopefully we'll identify what are the controversies, and we will also hopefully reach a consensus. So that will be my objectives for today. And just a brief recap, not going into too much detail of what Dr. Jatin has covered. We have a very brief therapeutic window of 6 hours where something has to be done. And this has to be done because 99% of hypoxic ischemic encephalopathy in the whole world occurs in LMICs. So we can't say these 99% lives don't matter. We have to do something. That is the basic fundamental where I am coming from, that we can't just be an ostrich and saying, okay, this happens, this HI happened, we can't do anything about it. So there are modalities, and therapeutic hypothermia is the most important and the most researched modality, though controversial. So the eminent panelist of today, thank you for being all of you. I'm sure you have come from, you have had to arrange your day in such a way to accommodate this session. Firstly, Dr. Guru Prasad sir has been senior. He has been a mentor to many of the people. I'll introduce one by one, Dr. Uma Maheshwari and Dr. Akash Pandita. Dr. Guru Prasad currently is a professor and HOD in neonatology in Davangere in Karnataka. He heads this unit from a long time. He has been involved in many academic activities in many boards. He keeps on papers only in LMIC, and this quality of research is wonderful, and they get published in international journals. He's also a good orator, and he keeps to the point. So I think we will be hoping to learn from him today as to what exactly to be done. So he will give you clear-cut messages at the end. Also, Dr. Uma Maheshwari, ma'am is traveling, but she's kindly agreed to be with us online. And she is the professor and head of neonatology in SRMC in Chennai. And she has been doing pooling, I think, for the past maybe 1.5 decades. So her interest, apart from hypothermia, is genetic and metabolic. Most of you must have heard her speak about genetic disorders and metabolic disorders. She's a very well published author in many journals, and she has won many awards. Also, together with us today is Dr. Akash Pandita. He is an eminent researcher. He brings to the table what systematic review he has done and on therapeutic hypothermia. He is also a very accomplished academician, now currently working as director of neonatology at Medanta, Lucknow in UP. So I think these three panelists are going to give us a direction of what exactly we need to know and where this hypothermia is heading, especially from LMIC and Indian point of view. So let me start by asking all the panelists starting from Guru Prasad sir, secondly Dr. Uma, and thirdly Dr. Akash, to share what has been your clinical approach and personal experience in therapeutic hypothermia. And I'm sure all three of you have been practicing hypothermia.
Yeah, thank you, Shashida, for the wonderful introduction. At the outset,
Changed, especially after the clinical approach in brief, and what are the contextual factors that influence your practice? Guru Prasad sir.
Yeah, thank you, Dr. Shashida. I'm audible?
Yes, sir, you are audible.
Thank you for this invitation from the NEOCHAP subchapter of Indian Academy of Pediatrics. And it was a great presentation by Dr. Jitin. I think I want to re-emphasize that amongst all the strategies of neuroprotection in perinatal asphyxia, probably the most evidence-based and very appropriately practiced practice is therapeutic hypothermia. At this point of time, I think we should acknowledge and remember Dr. Sita Shankaran, who is an Indian-based neonatologist serving in the United States, who has done all the pioneering work in therapeutic hypothermia. We should be proud that she is an Indian who has done great work, and she has visited India on several occasions. With that, like we have a level 3 accredited unit at Davangere, just 300 kilometers from Bangalore. And we are practicing hypothermia since 2017. Our experience is for last 8 years. At that point of time, I think the fellows who are working these days are very lucky. We are working in great units, wherein all the facilities are there. We have served newborn care when we had warmers and incubators as a luxury. We used to have innovative warmers during those days. And these days, we are talking about therapeutic hypothermia. Those who are working in good setup, you don't experience any difficulties. We started using Miracle phase change material in 2017. And till date, we have cooled more than 250 babies. And very coincidentally, in 2019, we had an opportunity to do an RCT, wherein we had started using Sensivision servo control cooling device in our unit. And we cooled about 70 babies comparing these two cooling devices. And interestingly, we noted that using servo control cooling device is clinically more superior. The temperature fluctuations were not really many, and it was more physiological when we use servo control. So for a resource limited, residents will think why you differentiate low middle income. I want to make the fellows very clear. You are working at district hospitals, taluka hospitals, medical college hospitals, and they are the places where they even doing arterial blood gas is a luxury, and MRI is a dream in so many district hospitals and even in upcoming medical college hospitals. So we have to really think of something which is very innovative, very, very economical. We wish to have decotherm in all the units, the other cooling devices, the imported one, but really they are luxury. When we started using Miracle, it was costing about 1,65,000 to the best of my knowledge. Then we started using Sensivision servo control cooling devices, and we proved, and that is published in Journal of Neonatology very recently, that servo control cooling device is very useful for a country like ours, wherein the cost of this instrument without EEG attachment to that was about 3.5 lakhs, and now they have an attachment to that, and totally it is costing about 8 to 10 lakhs. You are aware what is the cost of imported cooling devices. So I want to make the point very clear. Asphyxia is a burning problem in our country even today. And as Shashidhar introduced, the majority of the beneficiaries of therapeutic hypothermia come from countries like India. And fortunately, the referrals are earlier these days, unlike before. And we should initiate cooling within 6 hours, as you rightly said. Best in the first 3 hours, and the next best within 6 hours. And there is no benefit if we include these babies beyond 6 hours. So we need to have something which is very innovative, and And I strongly feel servo control devices are superior compared to manual mode. I think that we will have discussion in the course. I think that's what I want to say about that in the Indian perspective.
Yes.
Anything
And
in
I
particular,
think you're
will
right.
ask. Yeah.
Yes. I think it's going to come up the servo control versus manual, as well as what is your message. I think that's going to come up in the next few questions. So I think you rightly mentioned that you have been doing it, and you're doing it in a fairly research-rich setting. Though it's a government setup, and you're still doing it, and you're doing it with servo control. So, and you started with manual, like many of us. So, Dr. Uma Maheshwari, ma'am, can you hear me?
Yeah, I can hear you.
If you can,
Thank you.
if possible, can you switch on your video? That would be good.
I can switch on, but I do not know whether you will be seeing.
Yes. We can see you. Yeah. Please go ahead.
Yeah. Thank you, Dr. Shashidhar, for the question. As you rightly said, I think like we started way back in 2011 to start cooling the baby. So initially we had in cooling. So we have a frozen gel packs for which we were involved in the eccentric trial of phase changing material, which is meranthydal. So we kind of switched over to phase changing material, and also we used Blanketrol 3 as a servo control.
And there is some, I think, a network issue. You could talk if it will be. I think we lost Dr. Uma there. She's traveling. I think we will try to connect with her now. Dr. Akash is here. So, Dr. Akash, can you tell me what has been your
Sorry,
personal experience?
sorry,
Yes, ma'am. Sure. Yeah,
am I audible?
you're audible, ma'am.
Am I audible? Yeah, sorry, I'll cut the video so that like.
Yes.
Yeah, sure. So basically, like I was telling that like how we evolved from frozen gel pack to phase changing material and Blanketrol, but we do have two units. One is a medical college site where we care for lower income group without any ICU charges. So like there we use still phase changing material, and we also have a corporate side where we use Blanketrol. So our experience has been the temperature control has been good with both the devices, provided the nursing ratio is, it is 1:1. We always make sure that the nursing ratio is 1:1. So regarding like, if you want me to talk about the, other factors, usually like we kind of make sure that we do the MRA on day 5 of life. So the contextual factor is like when outborn is being referred. So whether we are going to follow the same protocol in outborns also, or we are going to modify. Definitely there needs to be a modification, because in our intramural babies, we are very strict in criteria in terms of there should be a card pH available. We do look at the card pH, space deficit, etc. Whereas there can be some lenience when we are kind of cooling our outborn. So this has been our experience. Our mortality has been very low. But having said that, our asphyxia rate is also very low. So we don't get very often asphyxia. So we would have cooled only less than 100 babies, even though we started in 2011 till 2025, because the live births being around 4,000 to 4,500 live births per year, the number of babies who required cooling are very less, because maybe the asphyxial rate is less. So I think that is what I'm.
As a follow-up to that, ma'am, after the Helix trial, have you changed your practice?
Okay, so actually that is a very valid question. The only thing which we do is taking a consent, because whatever has been put forward in the NNF position statement in terms of guidelines, we are already following in terms of very strict criteria, like in terms of entry criteria, moderate to severe encephalopathy, less than 6 hours. Um, so written consent, yes, we started taking written consent. Previously, we were convinced, our team was convinced that it is a standard of care. Following Jacob's article, especially the Cochrane review, which said that cooling babies, the survivors are going to be like have 1/3 less neurodevelopmental disability, and therapeutic hypothermia is going to reduce 25% death or neurodevelopmental outcome. With that, like, we started cooling straight away. But having said that, now we are kind of doing the consent, and also we are having a form for to score the moderate to severe encephalopathy. That is one more change which we did, which I will be elaborating further in the training session.
Sure. Thank you, Dr. Uma. I think she brings in both corporate India kind of side and also a government medical college kind of side. That's why these settings are important. Now, let me come to the pure corporate side of India, that is Medanta. Dr. Akash is from there, and also he's an avid researcher. So I think let's hear from him of his journey of therapeutic hypothermia, and has it changed, and what contextual factors does he consider before initiating cooling. Over to you, Dr. Akash.
First of all, thank you for moderating the session so well, and thank you for the kind introduction. So we have been cooling for more than a decade now, and just like any other modalities, I think hypothermia has evolved over these last 1 decade, and majority of the centers have now moved from phase-changing matrices to the servo control devices. I personally have used both, and I found that servo control devices are easy to manage. They are less labor intensive. Being a setup like India, where there are limited nurses, limited doctors, and there is evidence for less fluctuation of temperature. So I think we have totally moved to servo control devices. And one also has to remember that there is a difference between hypothermia and controlled hypothermia. So on one hand, hypothermia can land a baby into a disaster, maybe sepsis, acidosis, shock, IVH. Whereas on the other hand, babies who have asphyxia, again, we have to remember that asphyxia is one of the top 3 leading causes of neonatal death in a country like ours, and there is no much therapy or specific therapy available for this disease, except for therapeutic hypothermia. So there is already a sea of evidence which has been discussed in presentation, and we don't have any doubt that it is in fact the only modality which has shown to be of benefit in both decreasing mortality as well as morbidity. So we continue to cool babies, but we, after Helix trial, we have now become more stringent. That is, the inclusion criteria is more strict. We have to be sure that the baby is moderate to severe asphyxia, then only we have to cool. Milder forms of HIE, babies who have comorbid conditions like severe sepsis, intracranial bleed, or severe PPHN, those babies, or severe IUGR babies, those babies you may have to consider other modalities.
Yes, thank you to all three panelists. I think the message to a fellow here is that as well as science dynamic. So whatever you take for granted will come and bite your back the next day. So just like Ruma mentioned, we were not even taking consent, and now the question of whether to cool the babies or provide hypothermia itself is a question. So I think as science progresses, you will have to keep in touch, keep updated. That's the only way to go. So right now, coming back to hypothermia, the first question again, Dr. Akash. Sorry. I think you mentioned all this. Do you want to go through it again?
So again, there has been enough large RCTs like TOBE trial, NICHD, Cool Cap, ICE trials, and all the trials have again been showing the same, that there is a significant decrease in morbidity and mortality. And the latest Cochrane, which was published in 2013, again showed that there is decrease of mortality or a combined outcome of mortality and neurodisability by almost 25%. And similarly, there is decrease in mortality. So there is no doubt that therapeutic hypothermia is useful. But why we are debating then in this is that is because of a single trial which had various problems with it, which we'll discuss subsequently. And based on that single trial, that is which is the Helix trial, where 70% of the babies were outborn and their antenatal care was not known. The management in the first golden hour was not known. Just because based on that trial, we showed that slightly increased incidence of death and combined outcome of death and disability higher in the therapeutic hypothermia. They jumped to the conclusion that hypothermia should not be offered. And in the countries like ours, that is LMIC. But again, following this trial, we did our own meta-analysis where we included the Helix trial. And in that meta-analysis, we had around 10 studies, around 1,300 babies. It did not show any difference in mortality or combined outcome of death or severe disability. But I must admit that the studies which were done were of very low quality. There was a lot of bias in the studies. So it should be taken with a pinch of salt, but definitely there was no increased risk of mortality or morbidity with the hypothermia group. Based on these two data, that is data from the West and data from the LMIC, we need to be sure about our inclusion criteria. Sometimes the inclusion criteria in various setups is not stringent, and that's why we try to get a mixed results. Same had happened with steroids, where a single trial had shown abnormal benefits. Had we stopped steroids based on that single trial, we would not have reaped the benefits of steroids, which we are doing now. So I think one study does not change our practice. We need to be more wiser, and we need to collate more data and do a good RCT.
Sure. I think thank you for saying that. So one study shouldn't change practice generally, though it may be a well-conducted study. It may have shown a good outcome in terms of statistical analysis. But as clinicians, we should take more factors into consideration. So what are these factors which we should take into consideration before deciding cooling? So the role of morbidities, comorbidities, and what levels of care which impact therapeutic hypothermia outcomes. And is it possible to isolate the effects of hypothermia from overall good or bad intensive care? So those are the questions that I think Dr. Uma is going to answer. Over to you, Dr.
Thank you, Dr. Shashidhar. I think comorbidities that is an important consideration because like if we see the trial criteria, they would be more stringent. They do not want any confounding factors when they choose the patient. But that is not the same thing for real world scenario. So we might have to include some of the babies which with like either knowingly or unknowingly. Okay, so basically, if you take the comorbidities as such, so why are we worried about comorbidities? Because it can independently worsen the neurological outcome. So we might, we might kind of think that it is because of HIE or therapeutic hypothermia the baby worsen, whereas it might be a underlying sepsis or baby might be severe IUGR, which kind of worsens the outcome independently. Coming to congenital anomalies, we have to kind of really differentiate, see, because major congenital anomalies have been excluded in all the trials. But like what do we consider as major? Say, for example, if we have a Down syndrome baby and the baby has a HIE, or we did have in our unit a achondroplasia baby who had HIE, do we cool those babies? Because they are not lethal malformations. They are not going to die of. So actually, I would say that yes, I think they should also be treated like any other baby. So we cannot be kind of really stringent when we are applying those criteria. If they show very clear-cut evidence of perinatal asphyxia in terms of fulfilling all the criteria, I think we might have to include them. But we need to remember that they might be an independent factor to influence the neurological outcome. The next one, which I would think would be like because maybe my area specialty IEM. So because many of us, like including our unit protocol, seizure is an independent entry criteria for cooling. So in like I have come across a neonate with pyridoxine dependent seizure, who has been cooled because baby developed seizures within, baby did not cry at birth, had a HIE mimic, and the baby developed seizures within 6 hours of life. Even though the baby did not really fit into moderate or severe encephalopathy in other terms, in terms of tone abnormality or posture, because seizure is an independent criteria, we included that baby in cooling. So we need to kind of remember all these factors. And also the other one is multi-organ dysfunction. If there is multi-organ dysfunction, obviously like you would have like fluid and electrolyte imbalance that might also influence the outcome. So regarding your next question, level of care, I think level of care, yes, it has a very strong influence on the outcome because a higher level NICU provides better monitoring. There will be a very strict protocol. You have resource persons. There will be a 24-hour person who is trained in identifying and selecting the babies for cooling. So with all these factors, I think level of care definitely would influence the outcome. And also it is very difficult to separate, your third question, whether we can really separate. I don't think it is possible for us to really separate the overall ICU care from the effect of therapeutic hypothermia. But what we can, definitely say is, if the level of ICU care is generally good, then those are when they can provide intensive care support, even otherwise for a HIE baby, those are the units who should practice therapeutic hypothermia for optimal outcome. So that would be what I would like to convey across. Regarding clinical practices which influences, I think we should not forget, because this is the only modality available for HIE, we should not kind of forget all the other things, namely like for example, strict adherence to infection control practices, or like, choosing an appropriate equipment. So when, as rightly pointed out by Guru Prasad sir and my colleagues, if there is a servo control device available, to choose a servo control device, and identifying seizures by EEG and treating them. And deworming is one thing which I would like to mention in a clinical practice. Previously, like we did used to have like little bit faster reworming after identifying like certain issues in terms of hypotension and seizures which happens during rewarming phase. We kind of changed our protocol to 0.5 degree per 2 hours. Every 2 hours, they will be kind of rewarmed 0.5 degree rather than 0.5 degree per hour.
Right. So I think very, very important points coming out from there, that as we are saying that babies may not be different. Baby is the same everywhere, but the setting in which the baby is, that is the level of care, the policies, protocols, and what the baby also comes along with these IUGR, septic baby who has PPH, and all of this can influence mortality. All of them can cause independently increased morbidity, mortality, poor outcomes even later on. So we can't really separate therapeutic hypothermia from good quality intensive care. So if you have good quality intensive care, then there is nothing preventing you from treating your baby as if you are in a high income country. So, but if you don't have, then set that right first, and maybe then think of starting therapeutic hypothermia. So thank you, Dr. Uma, for that. Next, we'll move on to Dr. Guru to emphasize what are the things in LMICs which can be different. What innovations, I think sir also has some personal experience in innovative methods for cooling, and also has recently published some data on innovations coming out from India who for practicing therapeutic hypothermia safely and effectively. And is resource limitation really impacting this difference in impact between what you would have to do, sir?
Thank you, Shishidhar. I think that's a very valid question. I think if you're working in a good setup, a corporate hospital or a very, very nicely supporting medical college hospital, wherein we have state-of-art newborn care, then I think therapeutic hypothermia will be very easily incorporated into that. There is a mismatch, however, in low and middle income countries. There are high chances of birth as yeah. Any problem?
No, sir, please go ahead. I think, yeah.
Due to lack of resources in a country like ours, various other low-cost methods. This is what has been discussed since evening. People have used frozen gel packs, gloves, cooling fans, and phase change material mattresses. Can you go to the next slide? Yeah, I'm not going into details. All these were acceptable, but if you look at the published data about these things, innovative cooling devices, they are acceptable for a country like ours, but they have got great limitations. You can go to the next slide. The disadvantages of these things are there is uneven cooling. Like Miracle was one of the initial phase change material mattresses that are in use in the country for more than a decade now. There is uneven cooling, not achieving target core temperature with them, and there is the need for manual adjustments. So they are labor intensive. It needs dedicated staff round the clock next to the baby, and risk of local injuries like subcutaneous fat necrosis. I think each panelist and the speaker has highlighted an Helix trial that was a sensational publication which gave a wake-up call to all the researchers in the country, and the TNNF was in a standstill for nearly 6 months to take a decision on this and release the statement for the practice of therapeutic hypothermia in the country. Next slide. Yeah, as it is shown here, you can see that with all these devices, there is a great risk of problems like subcutaneous fat necrosis and laborious nursing input you need when you are using this. Next. Next, Shashida. So we need to improve the perinatal care, and we need to go for the servo-controlled cooling systems. In that context, during COVID time, we were involved in an RCT comparing the Miracle with a servo-controlled device from Sensevision, which is a Bangalore-based company. No funding from them. They were just involved in the research program. They provided the device, and we enrolled about 70 babies, and nearly a good number of them are outborn babies, and a good number of inborn babies. And this same inclusion criteria and induction was initiated, and rewarming was 0.5 degree per hour as recommended. And we looked at our data in terms of the temperature that we achieved. We could achieve the temperature, necessary temperature in both groups around same time. However, the cooling was more physiological without any fluctuations in the servo-controlled categories, and there were no significant fluctuations in the servo-control. That is very, very important. These two observations make servo-controlled devices more useful. Only thing is, when you are using servo-controlled, during our research time, we had one staff looking after that baby round the clock in each shift, so that there were 3 staff nurses who were attending to that. So our data got published in our TNNF Journal of Neonatology. Just we want to re-emphasize that servo-controlled devices are superior as against other modalities of cooling that is practiced in developing countries.
Yes, sir, I think you highlighted.
Any questions by the audience, you can take up later.
Yes, we will take up later. So I think you highlighted the need for innovations and also your personal experience on one of them. So I think all of us have started with phase-changing material, Mira Cradle, and now because of various factors, we have all moved on to servo control. And it's somewhat like indigenous CPAP versus CPAP, which is provided exactly by the companies with the blender, humidifier, etc. I think the device definitely makes a difference. So coming to Dr. Akash again, can we bridge this gap? So people are saying your LMIC, you should not be allowed to cool. And there is no data as to show to justify or substantiate your cooling practice. So how do we bridge this gap, and what are the ways forward in research in hypothermia?
Again, a very good question. I think we all need to collaborate together and do a good multi-center RCT from good tertiary care centers, both from the public as well as the private center, where we have a stringent inclusion criteria and we ensure a good number of inborn and outborn babies. And if there are outborn babies, we should ensure that we have a strict transport protocol, not just that the baby has been transported and we don't know about the details what happened to the baby previously after birth, especially in the first hour, then such baby should be excluded. Similarly, we have to use standard servo control machines. We have to be sure about, because scans are not available everywhere in every part of the India, so we have to be sure about the gestational age of babies before enrolling them. We have to rule out other comorbid conditions. We have to ensure good antenatal care to those mothers, and then these babies have to be recruited. Similarly, these babies need a good rigorous follow-up for at least 18 months or more, so that then only we'll be able to conclude with the good quality of evidence that it is beneficial and how much more benefit can it bring to the country like ours.
Thank
Till
you.
that, we need to
Yes.
continue practices and we don't need to change based on that single trial.
Yes, I think point again is very well taken, that though we continue, but we should also generate data to justify our practice and maybe do a good RCT, which is multi-center. Coming back to Dr. Uma Maheshwari, ma'am, I think you are also involved in the TNNF position statement, which is very comprehensive, which is very well taken and very well worded also. So can you elaborate on what is the position of NNF and of neonatologists of the country regarding cooling as on today?
Thank you, Dr. Shashidhar, for the question. So basically, like I'm there in the CPG guidelines, but I honestly I was not involved in this particular position statement guidelines for therapeutic hypothermia at that point of time. But however, it was done by experts. I think like regarding policies, after the Helix trial, like those who are already cooling the babies and those who have already got successful cooling in terms of their mortality is not very high. So we were all kind of really taken back, like what to do now. So this came as a boon because like something which we can kind of lean upon to continue cooling. So that is what honestly it came across as. So there are like very beautiful points addressed in position statement. So where should therapeutic hypothermia be offered? So it should be either a level 3 or level 4 unit who has the resource to manage complications related to therapeutic hypothermia as well as HIE. It's not just TH alone. And like as pointed out by Dr. Jitin also, like you should have facility for bedside ultrasound. CT we don't use generally, like unless we are suspecting a hemorrhage. MRI, of course, yes, like you need to time the MRI appropriately, and AEG and bedside EEG is definitely preferable. So apart from that, the resource person, what we need is a neonatologist who are there addressing all the issues, as well as the nursing ratio, the desirable nursing ratio being 1:1 or 1:2. So coming to the next one, like whom should we cool? I think as Dr. Akash has already pointed out, who should be cool should be very strict in terms of they should be more than 36 weeks or less than 6 hours, and the admission temperature should be 36 to 37.5. So why they have laid down this is because erratic or passive cooling instead of controlled cooling itself is causing harm. Whereas we are actually trying to interpret that the coagulopathy happened because of the controlled cooling, whereas it might be because of the erratic cooling which happened even before the transport of the baby comes. So that is why they have clearly given admission temperature for an outborn should be between, or to the unit should be between 36 to 37.5. So this is like whatever we are already following in terms of pH and base deficit, either as a cord or ABG, which is done within 1 hour. And Apgar, actually it used to be like R, now it is and Apgar score less than 5 at 10 minutes. And at least positive pressure ventilation for 10 minutes. So this is becoming more stricter than like what we used to take it as, okay, the baby did have asphyxia. Again, to see the effects of asphyxia, it is not just alone that the cord pH is 6.9. Like many of my trainees used to come and tell, ma'am, cord pH is 6.9. Can we cool the baby? So it is not just the asphyxia, but what is the effect of asphyxia on the baby, especially the CNS, because we all know that cooling is going to only cause more benefit to the neurological status as such. So moderate to severe encephalopathy. And this is very important, written consent from parents, or if the parents have not accompanied, from the legal guardians. So I think the comorbidities have been again insisted in terms of severe IUGR, severe coagulopathy. It is not just coagulopathy, because many of HIE do have coagulopathy. So Doppler changes have not been mentioned in particular. So IUGR, if it is mild to moderate IUGRs with Doppler changes also, we can include for cooling. So head trauma, moribund, and have major congenital or genetic anomalies. So basically, all these things are laid down because they do not want an already asphyxiated baby who has having chronic asphyxia to come into therapeutic hypothermia range. And which method, obviously, like all of us should agree that servo control is better. But if at all they are using other methodology, then the nursing ratio they have strictly laid down as 1:1. So moving on, what our position statement has not addressed, which other policies have addressed. So I would like to, you can go to the next slide. So I would like to kind of compare with the other guidelines which are there. So these are like ranges of guidelines which are released from North America, South America, Europe, Asia, Australia. So this is a very comprehensive but very busy slide. But what I wanted to bring out from this particular thing is the minimum weight criteria has not been laid down by NNF. So that is something like, we can adapt from the rest of the guidelines as such, or in the next revision, we could include the minimum weight. So next one, if you go to the next slide. So how we are going to assess the clinical examination and come to whether the baby has moderate or severe encephalopathy. So even amongst developed world, how they are kind of categorizing the criteria as moderate or severe encephalopathy differs. If you see here, not all of them cool for just seizures, but many of them do cool. Like you can see that South America do not cool just with seizures alone. UK, British Association of Perinatal Medicine, no. Japan unit, they do not cool just seizures as an automatic eligibility. So this is again a very busy slide, but you can see the variation in which they have categorized. Maybe this is something which we also need to work on when we bring the next position statement. You can move to the next slide. So other things are like, severity interpretation, when a specific clinical finding is found, or like what is the timing of evaluation. We know that we are in a very strict time frame of only 6 hours. Before 6 hours, we should have started cooling. So how much time do we have? So how frequently should we assess the baby? should we assess the baby every hourly, or should we assess at 1 hour, 3 hours, and then like just before 6 hours? So when are we going to again like assessment? Then if it is going to be a trainee who is going to assess, they are going to move on to the next hierarchical level. They need to take in consent from them. They need to discuss with the family. So there will be some time to communicate to the family to arrange for cooling devices. So whether we are going to stop our clinical assessment at 5 hours, 5.5 hours. So these are some of the other things which we need to bring in as such. And also seizures, which is a very important thing. Uh, even countries where they kind of do not believe in clinical seizures, for therapeutic hypothermia, they say abnormal movements, they include for cooling as such. So whether we are going to lay down more strict criteria in identifying seizures, is it going to be only EEG identified seizures? How are we going to utilize EEG? But one thing which is very clear in our unit after we bought AEG is when there is a dilemma and if it is showing a continuous pattern, we are all like, okay, this baby does not need cooling. This is only mild HA. It's going to kind of really improve. When we are kind of facing some dilemma, then definitely this AEG is coming to our rescue, even though we have not put in SE criteria in our unit as a protocol as such. I think these are some of the policy, but how do we, merge all these things is by, you can go to the next slide, like individual patient data analysis we should do. We should collaborate with units and we should have a common database. We should share our complications. So with all these things only, I think we can derive at a, common policy, and that is yet to come. Honestly, I do not believe in any RCTs further, because having like so much, doing an RCT on different, whether it is servo controlled or other device, that is a different ball game as such. But I'm telling RCT on cooling one limb and not cooling one limb. Honestly, I am not for it doing RCTs, but like, there can be difference in viewpoint as such. But more important is to have a common registry and to see how they are doing in the follow.
Yes, absolutely. So I think real world registry data compared to clinical trials is what you would advocate. So there were few questions related to your answer. One was one question I think from Dr. Prakash. He was asking whether do you take NIV or CPAP for 10 minutes as PPV for 10 minutes for starting cooling as the inclusion criteria, ma'am?
Actually, it is like, according to the NNF position statement, it is positive pressure ventilation. I kind of understand that, see, that is very similar to the TP's device with a mask. Okay? And again, we need to remember that it is just not the requirement of positive pressure ventilation, but also like how the clinical assessment on to how severely the baby is asphyxiated. If you are going to tell me that positive pressure ventilation, NIV is a form of positive pressure ventilation, then yes. But if the baby has not had spontaneous breathing and I'm going to deliver a positive, actually, I have not thought about it. But if you are going to interpret in the same way that it is just by giving mask, instead of mask, you are going to put another interface for delivering the positive pressure ventilation, then yes.
Yes. So I think the question comes from if the baby has weak efforts, or you don't give positive pressure, but you give CPAP. So would you consider that as cooling? I think the answer is no. It has to be positive pressure ventilation given for asphyxia. So I think that's where NNF has its word in spirit. It may not be very well in letter. There was another question asking, what is your difference? Have you seen any difference in outcome between your corporate center versus the other side, or is it the same?
It has been the same because the protocols are same, the consultants are the same, and the nurses are very well trained. and we make sure that we give 1:1 ratio. Sometimes very, very rarely, like if we have two babies and one baby only will have servo control, the other baby will automatically go on to the phase changing device only. So I think as far as the temperature control is very strict, and you are going to maintain the temperature. Actually, that time, like I was looking at the Canadian registry, which is live experience, how they have done and how they are reporting. And they have a very transparent reporting system, the whole Canadian system. They 25% of the time they have been outside the between 33 to 34. So I think we should also audit ourselves. So we might be kind of complacent and think that yes, we are maintaining temperature between 33 to 34. Are we missing out on this aspect? Are we really able to maintain temperature between 33 to 34 degrees? So these are some of the things which we need to audit ourselves or do a quality improvement initiative to improve on those aspects. Dr. Shashidhar, did we lose him? Am I audible?
You're audible, ma'am.
Yeah, I think we lost Dr. Shashidhar, I think.
Yes, ma'am. Dr. Shashidhar is not there now. Meanwhile, I think we can take questions.
Questions, yeah, I am. We are happy to take questions. I'll see what is. There's a device that can provide a transportable cooling device with a built-in AEG help you in better assessment. Actually, more than device, it is the assessment which is important. Like how we are going to assess a baby, whether this baby is eligible for cooling or not. There is no haste in cooling because you do have 6 hours. Unless the transport is going to take that much long. It's a good idea. Maybe it might come up in future, but even the developed world do not have a cooling device on transport as of now. All recommend to bring the baby as euthermia to the unit and assess the baby strictly with very very objective way of assessment as much as possible. I know that the neurological examination itself is subjective, but as much as possible, a way of assessment and scoring with a very strict scorecard, and then include them. There is actually, in my opinion, there is no hurry in starting the cooling in the referral unit itself, because the temperature control or temperature maintenance is very, very important. And the initiation phase, the baby is going to come from euthermia to the control temperature. It is going to take some time. What's your opinion on AEG? I have already given. Whole body versus selective head cooling. I do not have any experience on selective head cooling. If Sir and Dr. Akash had any experience, they can share. We always do whole body cooling. From the time like we used either a frozen gel pack or phase changing material, or like servo control, we always use whole body cooling. And Dr. Akash, or Sir, do you have any experience on selective head cooling?
I don't think any one of us in India has used selective head cooling because there is no data to prefer it over whole body cooling. And as has been pointed out in the presentation, it does not lead to uniform cooling of the body. So it is not preferred. Also, it interferes with the monitoring of the baby.
Yes, I think there was only one trial with cool cap trial which showed that. I think that it's largely abandoned
For selective head cooling compared to whole body cooling.
Yes. Thank you. So I lost my battery, so I think I have logged in. I hope we can continue without the slides. So now next question to Dr. Guru Prasad. Sir, what are the current ethical and legal concerns? We have discussed some of them. So can you share your thoughts on about cooling in LMICs? What are the current ethical and legal dilemmas that a person may be having?
Yeah, thank you, Dr. Shishir. Just before Dr. Uma was telling that the Canadian study, the effective cooling time was very variable. Out of what we have monitored in our study, I want to share that the effective cooling time in servo control group was about 91%, as against 60% in manual mode. So that was of statistical significance, again proving that servo control device practice is superior in our setup also. What is very important is in today's topic is it's an intervention that we are talking about. So it is very important that we discuss it in detail with the family members, preferably the parents, otherwise the guardians who are accompanying the baby. We have to explain to them in detail what we are doing and what is the plan. Like up to 72 hours, we are going to cool the baby, and then subsequently we are rewarming. And it should be a written consent that we have to take. As it is the standard of care in the rest of the world, there is no difficulty in convincing parents to take a written consent. But it is very important that this consenting should be ideally done by a senior postgraduate student or a junior faculty in the department, because babies get admitted beyond working hours. You can't expect the faculty to come in the night to take consent. But a person who is very knowledgeable about this practice should be given the responsibility, and you should take the consent of the family, the parents, after informing the doctor in charge of the consultant in charge. And you should explain to the family the possible clinical course, and in the course of the treatment, baby may worsen in terms of hypoxia-ischemic encephalopathy. You may have to stop the treatment if it progresses to severe hypoxia-ischemic encephalopathy. And for example, when we took an ethical clearance for our study, the ethical committee had very serious concerns. They said if there is something bad happening, are you prepared to reimburse, or you have going to give the insurance claims of the family, all that. So all those things need to be made very clear when you are initiating the cooling to the baby. And you should explain to the family in detail what we are doing. And if possible, the parents should be allowed to see the baby when the baby is undergoing treatment. Some of the units strictly don't allow anybody, at least in this medical equipment related interventions. I think we have to be very careful with the family. Otherwise, we have to face litigations and legal issues if you don't explain to them very clearly. I think I want to make the point very clear. The ethical clearance should be taken from the family by a person who is very knowledgeable, a senior member of the treating team. That's my that's the point. I want to make it very clear. It should not be very casual like in other papers. Everything should be very thoroughly explained to the family.
Absolutely, sir. So I think very clear statements again from our panelists here. Coming to last few questions, Dr. Akash, is there a role for international collaboration, maybe to identify what are the gaps and what we can do, and what are the ongoing technological advances which we can implement in the next few years? Dr. Akash, can you hear me? Dr. Akash?
Akash sir is unmute. Akash sir, please unmute yourself.
I think when he's getting ready, can we have Dr. Uma Maheshwari? Ma'am, what are the training requirements? So everybody mentioned about training and education, nursing training especially. How to implement this and what have you done in your unit?
I think a very pertinent question as such. I think because sometimes we do get kind of complacent that we know things. Initially, pre-conference, like if I have to tell from national level experience, I'm kind of we are involved in conducting pre-conference workshops. So like a workshop is also a very good way of learning, and NMC also recommends therapeutic hypothermia as one of the recommended workshop for DM. Maybe it will be suitable for DRNB students also. So conducting workshop is one way to train them, but that alone is not enough. Definitely we need some ongoing. Simulation exercises we kind of do for our residents. So we take from NRP, like NRP baby has not cried, then what will they do? What will they consider? How they are asking for help? What are the, how they are arranging for cooling? How long are they taking? How are they communicating to the parents in terms of explaining the procedure and process and getting consent. So simulation is also a way forward for doing a training, and that would kind of make them have an experiential learning, I would say, and debriefing after that. So that is one of the things which we do regularly. Case selection. I would like to, make the whomever has joined the fellows who are getting trained in different institute to give importance to the case selection, because that is the one which is going to determine the outcome. So we should be very vigilant in identifying which are the babies who needs cooling. So certain criteria are very easy. Okay, of course, maybe sometimes the gestational age may not be um, you know, very evident. They may not have antenatal, except for those factors. They are like gestational age, birth weight, etc. So those are like very straightforward. Maybe card pH, other objective way of assessment. Do you want me to share the slide? I can share the slide, Dr. Shashidhar.
Yes, ma'am. If you have, you can share.
Yeah.
I will stop sharing once.
Okay, sure.
So, sir, your battery is running low, mobile's battery.
Yeah, I think we can manage, sir.
Okay, sir.
So is my screen visible?
Yes, it's visible.
One second. Okay. So basically, this particular chart, this like we started implementing or being strict only, for the last few years, I would say. How do they really identify and categorize as moderate or severe encephalopathy? So what do they do if they get equal numbers of moderate and mild encephalopathy? So do they put on moderate or do they put on mild? And what is the factor which say, for example, it all depends on the level of consciousness. If the level of consciousness is falling on moderate, you have 3 on moderate and 3 on mild, you put it as moderate. If the level of consciousness is like uptended or comatose, and you get 3 on moderate and 3 on severe, you put it as severe. So depending on the level of consciousness followed by tone, so they will determine the severity, because it does have implications. Between mild and moderate, we know that it is an entry criteria itself. So training is needed for this. There are beautiful videos, which are there in various resources, which can provide information on how to do this scoring on moderate to severe encephalopathy. So we do, a lot of times in the rounds we discuss on this particular case selection as such. So how do they identify and correctly categorize as mild moderate? So though it kind of sounds simple, they need to get a hang of it, and it needs to be validated at the next senior level before we decide that this baby is going to go for cooling. So that is one thing which I wanted to insist, and also the protocol familiarity. So if we are going to like what is the present protocol which is being followed, that need to be. And also for the nurses, credentialing is very important. So a nurse who is just 3 months old and she just has joined, she cannot straight away be allocated to take care of your cooling. So that is the highest level which we think should be some more than ventilator care, because this is very temperature dependent. Even when the baby is passing meconium, if the rectal temperature probe is going to come off along with the meconium, then it is going to be erratic. So she needs to be very vigilant, and she needs to be monitoring the temperature irrespective of servo control, or because it all depends on the rectal probe. If the rectal probe is not placed correctly and it is not fixed correctly, we might be thinking that no, we are doing good, whereas we might be really harming the baby. So the credentialing aspects from the nursing side is very important. I think QA is a way forward for any implementation. So you have protocol and guidelines in place, but how do we make sure that it is taking off in the unit? So it is only by quality improvement initiatives we can kind of iron out things which are which are there here and there. So I would think that these are the way forwards for training and education.
Yes, yes. I think, thank you, ma'am. Wonderfully said. I also like the way how you brought in all your pet aspects of favorite things like simulation and genetics and QA into your answers. I think that was also wonderful. Dr. Akash, if you're there, can you talk about international collaboration and also any technological advances? I think he's muted. Okay. Otherwise, I'll come to Dr. Guru. What about your message to our pediatricians and neonatologists and a lot of neonatal fellows who have joined us about this practice? I think all of us have given an overview about what to expect, how to cool. We have gone on to the nitty-gritties, gone down to basic levels, and what we need to do to just implement this program. It's just not a drug that we can give and close our eyes. It's a totally package of intervention. It's not only therapeutic hypothermia that's going to work. So what is your message to all the pediatricians and neonatologists?
Thank you, Dr. Shishidhar, once again. I think the participants who are attending this wonderful webinar should take home very clear message that therapeutic hypothermia is the standard of care for babies with moderate to severe hypoxic ischemic encephalopathy. There is no second word about it. And only thing what we should remember is the NNF policy statement has been very nicely discussed by two of the members. So we should very strictly adhere to that. My concern, because I'm working in a teaching hospital, I see a lot of fellows who pass out and start working in small nursing homes and even not even level 2 units. They start cooling, they start doing all the other advanced interventions, all that. Unless you are really trained in that and you have a trained staff nurse and you have at least a level 3 accredited neonatal intensive care unit, not necessarily certified, fulfilling all the criteria, they should look forward to undertake cooling in their units. Most second important thing is there should be a committed person who is working round the clock.
Hello.
And the residents and the trained staff nurse. Even if you are using so-called servo control, as far as possible, use servo control methods whenever it is possible. And as we start using these equipments more often, unlike a decade before, even the imported versions of Ecotherm and other devices are much economical than what they were priced a decade before. And strictly follow the standardized protocols, whatever that has been discussed for the last 2 hours. Keep yourself updated as more and more data and information accumulates. There will be small changes in the recommendations that are made. So every 2 years or every 3 years, you keep yourself updated with what is happening in this particular field of medicine. Be aware of legal and ethical aspects. This is very important because this is an important intervention that you practice, as it has been discussed earlier. keep the family well informed about what you are doing, keep showing them the clinical course of the baby until the baby is removed from the cooling, then subsequent to the NICU. In using therapeutic hypothermia, be sure of having adequate resources to provide the best care. And we are working in set up some of these government schemes to support this practice when the babies are referred from outborn babies. Otherwise, it amounts to a lot of money to the family. That all should be explained very clear to the family members before you start, because I see this being charged anywhere from 8,000 to 30,000 per day in different hospitals across the country. So this is a cost incurring intervention. The family should be very clearly told about it, just not starting the treatment. So ensure that you are prepared in terms of your infrastructure, manpower, monitoring devices, and if possible, you have imaging facilities like MRI and around the clock arterial blood gas facilities. And most importantly, once these babies are discharged, the pediatrician should ensure that they are followed up at least for initial couple of years. You can time it with your routine baby follow-up clinics and the immunization visits that they come if you don't have a structured follow-up of these babies. That's what I want to emphasize. Not treating is enough. A good follow-up of these babies should be planned at the time of discharge, Dr. Shashi.
So very clear messages. So it's not only the intervention, it's the system of where you're working and how we are working, which matters if you want to improve outcomes really. And these points I think are very well said. You can copy and paste this into any of your answers of if they ask you who has to cool and how to establish a cooling therapy, then this answer would be really up there. No, I think we agree on all that. Dr. Akash is back. So I just wanted to ask him about any technological advances that we can hope for in the next or any ongoing trials on hypothermia, or is there a role for international collaboration? Yeah, over to you, Dr. Akash.
Again, a very important question. And now recently there has been some evidence to show that even babies with mild HIE can have benefit with therapeutic hypothermia. So again, that constitutes a huge chunk of HIE babies as such. So one thing is that is still evolving, and there is some good evidence to start with. And but again, there are more trials which are ongoing, and the results are still awaited. Regarding the solution of our problem, so since the problem is ours, the data has to come from our side only. We cannot just copy paste the data from the West and use it for our population, because our population is totally different. Our problems are different, including low birth weight, sepsis, IUGR babies. So again, as we already discussed, that we need to respect our data, collate our data. We have good numbers in India. We don't have a problem with the numbers, but the quality of data has to be ensured. The data has to come from good centers. They say whatever you put, you get the results similarly. So a good quality data has to be collected, and either in the form of the registry or an RCT, it has to come within ourselves. Regarding other things which we can collaborate is regarding the devices, like we can uh, think about low cost devices which are servo controlled. Similarly, tools like NIRS, again the cost is a huge issue. So something, a device which can be used both during transport as well as in the unit, which has an integrated AEG or NIRS. Recently there is a device in the market which has hypothermia as well as EEG in place, but again that
Yes.
can be made as a transport tool, and so we need innovation in that front. Regarding data, it has to be we ourselves.
Yes, agree with all the points that you said. The data has to come from us, and it need not be randomized controlled trial data, as Dr. Uma Maheshwari mentioned. Ma'am, last word to you. Anything you want to add as a message? Thank you for helping me out with the slides. So please feel free to give the closing remark for this panel discussion.
So before I move on to closing remarks, recently we did publish in Pediatrics and International Journal of Pediatrics and Child Health regarding the therapeutic treatment is happening for mild HIE. So though Dr. Akash has brought in an important point that there is a growing evidence, as of now, we do not have enough evidence to cool mild HIEs. What is very evident is HIE do have neurological problems, so they need a very proper follow-up. Mild HIE do have problems, so they need a robust follow-up, similar to moderate and severe. So that is very clear. Maybe even we could consider doing an MRI. But as of now, we are kind of restricting ourselves to moderate to severe encephalopathy. Dr. Akash, we can debate on it, and I can share you the article which we have published. So that is on the mild hypothermia as such. So coming to the closing remarks, I feel the selection criteria is very important. The fellows who are getting trained in different institute, please be aware of the selection criteria, because that is the main factor which influences the outcome. So when we know that the primary energy failure has happened very recently, you have to remember that those are the babies who are going to be benefited by therapeutic hypothermia. So not the one who is having chronic asphyxia. The one point which actually I wanted to bring in, and I did not bring in any of the discussion, is it is a good idea to send the placenta for histopathology, so that will give us an information on whether there is an acute inflammatory change, or there is a chronic villitis and chronic inflammation or placental infarction which has been there. That is why, in spite of therapeutic hypothermia, the baby has not shown neurological improvement or deteriorated. So we have a diary of what the baby spent in the 365 days in front of us that is being only underutilized. Maybe placental histopathology is one way forward. Of course, we have to do an MRI to find out whether it is an acute or chronic. Sorry for making it long. My take home is case selection is important.
No problem. I think points very well taken. Though we may not have results of the placental histopath before you decide to cool, obviously, I think it's going to have a major say on prognosis. So I think with that, we come to the end of the discussion. I thank all my panelists for a wonderful discussion. I think we covered the whole landscape, from why there is a debate of what is the current evidence in LMICs of why should a HIC baby be different from a LMIC baby? What are the contextual factors of hypothermia? And then coming down to consensus of mainly focusing on the NNF position paper of which setting and which babies and how to follow them and what instrument, what equipment. I think most of the fellows would have benefited from this discussion, and they have a clear idea of what to do in case they want to implement therapeutic hypothermia in their units. So I think Dr. Jatin Mistry also started off from his talk very well, and we took it forward from there. Whatever messages I see in chats are really comments, and we agree with all of them. Unless you see any questions, Dr. Uma, we can ask any of the audience to unmute and ask any questions, or you can type in the chat box as well.
I think one question which went on without answering is, how do you manage PPHN? That per se is a big talk. But what I would like to say here is, if there is a mild PPHN, sometimes we do have considered starting on INO, and then if the baby settles down to cool. But very occasionally we have even stopped cooling because of severe PPHN. It has gone either way. So PPHN, definitely there is a concern. But I would say, in the whole set, maybe one baby we might have stopped cooling because we are not able to manage, in spite of starting HFOV, INO, starting all the measures. The PPHN is so severe that baby is becoming hypoxic. Maybe Dr. Akash and Sir can share, and Dr. Shashidhar can also share his experience on BPHN.
Yes, Dr. Akash, anything else you need to add?
I think, as rightly said, very rarely, sometimes if PPHN is very resistant and it's not responding to any therapy, we may have to stop cooling. But again, it is 1 in 1,000. Till now, I don't
Yeah,
think one
right.
baby we have stopped.
Any other closing remarks from your side?
I think we just have to be sure about 5 things. Just remember 5 things. Be sure about the disease, be sure about the baby, be sure about the device, your unit, and follow up. If you're sure about these 5 things, you are good to go. If you are not sure about one of these 5 things, please don't cool.
Yes, very well said. Sir, Dr. Guru Prasad, sir.
I think Dr. Uma Madam just in closing remarks nicely said, if you have the information from histopad, from the placenta, it will add to our understanding. I'm happy to share, in that context, we completed a project 3 years back called Purpose Project to understand the cause of death. And we have studied nearly 3,500 placenta from 2 sites, one in India and one in Pakistan. And very interestingly, we have demonstrated that there is little vascular malperfusion and from both the fetal side and from the maternal side. And there's now both the primary papers are published in Lancet. So the placenta plays a very crucial role in the fetal health. What has happened in the mother's womb will just be translated subsequently once the baby is born. So we won't have much information, but we should have a high index of suspicion, and a lot of things would have set in the last few hours or couple of days before the baby is born. Just want to add on to that. Thank you, Shishir, for this opportunity.
Thank you, sir. So I think that with that we come to the end of the panel discussion. So I again thank all the panelists for their time and their effort in coming for a late night panel discussion. They say knowledge is knowing tomato is a fruit, but wisdom is knowing not to put tomato in a fruit salad. So I think we all have knowledge of therapeutic hypothermia, but we still need some wisdom of, and I think we are evolving there, whom to cool and when not to cool as well. So with that, I hand over to the organizers. Thank you.
Thank you for the invitation, Dr. Suman. Yeah.
Thank you. Dr. Deepen, you want to make the closing remarks?
No, I was just handling to you, ma'am. Hand over to you. Yeah.
No, I just wanted to thank all the panelists for making this interesting. And our idea in IAP NEOCHAP is to have such controversies discussed every month, so that it's something that not only the students look forward to, but also the teachers. So I think we have achieved this. And this recording will also be available on IAP NEOCHAP website, so people can go back to it. And thank you very much. And I'm sure that people will call on you all and other faculty for more such meetings. Thanks, Deepen, for organizing this well, Shashidhar for moderating it so well, and definitely Akash and Sir Guru Prasad Sir and Uma doing it so very well. And Jatin, thank you so much. Thank you so much for getting it going so that they could talk about the controversies.
Thank you so much.
Thank